Thank you, Mr. Moderator. Thank you. Good afternoon, ladies and gentlemen, dear colleagues. We are very honored to be here at Jeju Island, to be invited at this International Symposium of Megagen to speak about a topic who we are very interested in, Tommy and I. So it is a dual presentation, and we will try to be a little bit interactive and to give comments on some topics and cases we share with each other. So we all know in our practices that not all those nice ladies come down, but that smile has evolved. It is very important that nowadays you get a very nice smile line, and not only in implant dentistry but also in restorative dentistry and in other dentistry disciplines. There is an enormous focus on smile line and broad and bright smiles. So we are very interested in the implant dentistry to have control of the architecture. After we do an extraction, we want to control this architecture of the tissues, the hard and the soft tissues. But therefore, we need some biology. Preservation is dictated by the biology, and so if we do implant dentistry, we not only have to place the implant in the osteotomy site, but we have to think about biology and these things. So, for me, it's very important that architecture is defined, first of all, when you do an extraction in a central incisor, that the bone to tooth contact is very important. That dictates when you will have a papilla forming or not in the future. And secondly, location of the implant abutment is very important, and so that can define also your aesthetic outcome afterwards. But not only the architecture, but if we want to have the architecture, we need also to have the technology, and we have a lot of things seen yesterday and today of technology, of the Megagen technology, who is evaluating very fast, in my opinion, and that's very good for implant dentistry. So, very important that you have no micro motion, that you have a good conical seal, that you have good biocompatible materials, and that you always have a mucosal design who is adapted, who is appropriate for that region. And last of all, you need then the biology. The biology will dictate what it will be in the future. The response of bone to tooth contact is dictated by biology. Because if the bone is away, you have to regenerate, or you have to focus and say to the patient, okay, you have to accept that recession of the papilla. That's a very important thing, I think. Then go to a case. This case is a young guy, 23 years old, and he has the problem that his central incisor was lost. The tooth 11 was lost. There was a periapical fistula at this site, and there was a follow-up by the endodontist, but at a certain moment they had to decide to remove that tooth and to replace it. In this case, we did the stage approach, the early delayed implant placement. We used the technique proposed by Danny Boozer. So we opened up after 2 months the flap, we placed the implant, we did some guided tissue regeneration with BioOs and biomaterials, BioGuide on top of it, and here you see the result after opening the flap and placing a healing abutment. But when we go to the literature of Danny Boozer, we see that it is a stable position. You get 3 to 4 millimeter apicocoronal tissues, and also at the buccal lingual sides you get 1 to 2 millimeter tissues. So you can go for a predictable treatment. But here we see the final results of that patient. The final results is good. We have good healthy soft tissues. We guided the gingival tissues and we adapted our prosthetics by forming rectangular crowns at the central sites. But if we consider that patient, he was along during 1 year to have that treatment. It's a long way to go. It's a big building up, some pain, some swelling and so on. So I think maybe Tommy can guide us through some shorter treatment times and maybe some easier treatment procedures to have even good or better results in that situation.
Thank you. On my behalf, I also would like to thank all of you and, of course, the organizing committee for inviting us here. We are very excited. Talking about architecture, talking about aesthetic implant treatment, it seems very important to establish peri-implant tissues that are stable in the long term. And for me, what really is the issue is not implant placement, because we know that today it is possible to, from a surgical approach, to install or to integrate our implants. For me, it is not a critical issue to provide nice ceramics, because if we work with a master dental technician, then they will give us superior outcomes with our crowns. For me, what is important is what I call the transition zone. And that is, I think, today the challenge, because it is what will determine a harmony between the pink and the white aesthetics. And for this reason, I'm a strong believer in the impact of abutments. So we want to create a stable soft tissue seal. We want to create or to preserve this peri-implant architecture to mimic Mother Nature. And you will see some cases during this presentation. We do not have one single protocol. Often Philippe and I, we discuss about the perfect approach for one treatment. Not always we agree, because I think there are more ways to treat a patient with predictable results. More than doing or applying one protocol, I try to apply certain principles that we know from the literature in my everyday treatment. First of all, I like to work with a minimal number of interventions, because we know the more surgeries you do, the more volume shrinkage you will have. I want to preserve the tissues that we have. I want to preserve the architecture that we have. If the tissues are lost, you will have to create it. You will have to augment it. We do not only work in a minimally invasive approach for our surgical techniques, but also for our prosthodontic techniques, because we know that being minimally invasive, that this will reduce surgical trauma and less volume shrinkage, and on the long term, less peri-implant bone loss will support the soft tissues. Let me show you one case. This is a patient from Holland. She had a very rough party in Antwerp. This is Dieuke, and during this party she was hit with a broken bottle. You can see the scar in her face. She had to see a plastic surgeon to correct this. But there was also a problem in the mouth. She had the upper left canine that was fractured. We discussed and we diagnosed the case, and the tooth had to come out. The fracture was too deep. So at the time of extraction, we like to work with this minimal invasive approach, very careful extraction, working with the periotome around the root, taking out with just tweezers. And then we analyze. We have hard tissues. We want to preserve the hard tissues with a slowly resorbable or even a non-resorbable biomaterial. And then we also want to preserve and even a little bit augment, boost the gingival tissues with a connective tissue graft that is taken from the palate. This is a very nice example of a suture that I use a lot to slide in my connective tissue graft in a buccal and a palatal pouch. We call this the saddle connective tissue graft to cover the biomaterial, and you can see that our instruments become smaller and smaller. We work with microscalpels, microblades. We work with sutures that go up to 6.0, in this case even 7.0. So this is the case as it was at the first day of the surgery. We did not decide to do an immediate implant. And this is the pictures of the same case, and you see the very nice bulky tissues on the buccal aspect. Okay, after 2 months we go for implant placement, again with a minimal approach. In this case it was flapless. Implant is placed in its ideal three-dimensional position. We install a provisional crown, and then this is the definitive abutment and the definitive crown that was placed by one of my colleagues. This is the same case after 18 months of follow-up. So we will have very nice and stable tissues, and Wiebke was very happy. And I was happy as well. But Philippe, I think for a case like this, we do know that for single implant treatment we can be quite predictable in the terms of the aesthetic outcome. But Philippe, do you really think that this is a big challenge for you?
So, Tommy, if you show me this, you show me a solitary case. It is, I think, a challenge to provide nice aesthetics. But for me, the real challenge, after being 20 years in the business of implant dentistry, I think the real challenge is that two elements next to each other, replacing by implants, is rather difficult. It's not a very easy solution, especially when it handles about central incisors, when you need to remove and restore the central incisors. Like this case. This case, we have tried to do everything we could to establish nice aesthetics and give the patient very good smile line. So we approached that case by doing tooth by tooth, and first of all doing the 11, and then secondly, after replacing the 11, doing the 21. So we do the stage approach with the two adjacent teeth, and we placed here also connective tissue after the extraction to build up the tissues in the next sessions. So we placed an implant in the place of 11, and then we go for the next treatment, doing extraction of the 21 and placing the implant in the place of 21. So this was done at this side here, at the left side of the slides. Also, we placed some connective tissue to build up the tissues. We know in the front region, the more we go for connective tissue, the better will be the aesthetic outcome. So we build up all the tissues maximally. And then we used the new technologies here, using zircon sound technique to make the abutments and to make also the crown and the zirconium abutments. So we have here the screws, the Palatin view, and the abutment design that the technicians can perform. And we always use in that cases abutments who are metallic ceramic abutments with the titanium base, and I've seen here at the Megagen company that they use a lot of these titanium based abutments with zirconium on top of it, cemented on top of it. I like these abutments very much because I don't like too much zirconia in the conical connections, because maybe in the short future there can be problems of that zirconium in that conical connection. Here we connected the abutments in the tissues on the implants and also placed the crowns on it. But for me, when I go to the final result, I have a little bit of problems to go back and reflect on this patient. For me, it's a little bit an arc of that, because I am not so very pleased with that result. I tried to do everything I could, but somewhere I had some problems to have it in a maximal aesthetic way. So I think we have to consider here that something went wrong. We have to be honest with ourselves and reconsider the things, rethink how we could maybe achieve better results. And I think, Tommy, maybe you can elaborate a little bit on that to show us how can we do it with other technology in nowadays.
Well, to be honest, Philippe, if you ask me what went wrong, I think maybe in the first place, or maybe most important, is the indication itself. Like you said, maybe it is just not possible today to install 2 adjacent implants and have excellent architecture of peri-implant tissues. Maybe that is the main reason. Secondly, I think we could discuss about the abutment design. Let me explain you a bit how new technology can help us today in creating the ideal abutment. I'm going to talk about the design of abutments, the timing of abutments, materials that we should use or moreover not use, and decontamination of implant components. What do we know about the connection? And I'm going very quickly over this topic because the previous speakers addressed this very well. We do know that the implant abutment connection with a switching platform, an internal connection and a conical seal or a Morse tapered design is superior than flat-to-flat connections. We know this. This is proven. This is in the literature. So whenever this is possible, we like to use such an approach. The submucosal profile of an abutment, in my opinion, should be concave. It should be wide enough to support the tissues, to support the architecture, but it should be concave to allow for a wide zone, a thick zone of soft tissues around your abutment. Because we know from the literature again that thicker tissues will be more stable. And not only for the soft tissues, but also for the hard tissues. Secondly, an advantage is that the thicker the tissues, the less problems you will have with shining through of implant components. And as soon as it goes over 2 millimeters, this is ideal. So that is a reason for me to have a concave design of your abutment under the level of the mucosa. What do we know about the emergence profile? The emergence profile, that is very easy. That is determined by our diagnostics. And we refer to aesthetic criteria. We refer to smile design, extraoral parameters, golden proportion, central dominance of incisors, a gingival balance, and then pink and white aesthetic parameters that we know from the literature. Someone who has written a lot about those parameters is Urs Belzer. So the emergence profile is determined from our diagnostics, and then the shoulder of the abutment should be located ideally 0.5 to 1 millimeter below the ideal emergence profile. Not too deep, not to risk to have cement remnants under the tissues. Then the body of the abutment should be strong enough to withstand occlusal forces. There is this one study that was done in dogs showing that every time you connect and reconnect implant components, and in conventional treatment protocols we do this quite a lot. You see here on the screen some of the implant components that we used. Every time you reconnect, you will disturb peri-implant tissues, resulting in apical migration of connective tissue and a more peri-implant bone loss. So from a theoretical point of view, or based on this study, it seems to be a wise idea to install a definitive abutment as soon as possible maybe even in some cases immediately after implant surgery. And this is not only shown in dog studies, now we have clinical data as well, showing that this one abutment or one step or definitive abutment, immediate abutment, is a valid protocol. This helps us in stabilizing our soft tissues. Acrylic is poison for the soft tissues or for the peri-implant tissues. I do not like to see conventional, or I do not like provisional crowns with a design, as you can see on the upper right part of the screen, with acrylic going towards the implant abutment connection, because acrylic will cause additional recession and volume shrinkage. We have more plaque gingival indexes, more pocket probing depth around acrylic restorations compared to other restorations. Apparently gold and feldspathic porcelain cannot form any mucosal attachment as well. So those are no materials that we can use for abutments. Palladium, nickel palladium, or cobalt chrome cause immune reactions that are similar to reactions towards bacteria. So in my opinion, those are no materials that we can use for abutments. The only materials that are biocompatible are zirconium, titanium, and aluminium oxide. Zirconium seems to show a little bit less inflammatory cell response around the abutment, and if we ask our dental technician to have a very highly polished surface of the abutment, it seems that the epithelial cells like this more than the rough surface. And as Philippe told you before from his case, in cases where you think that a zirconia connection in the inside of the implant is not a good idea, or there's too much force, then we like to use intermetallic components because this is stronger, this is more withstanding to fracture. This is a very nice article. It seems to be that when you receive your implant components from even the company, and you can read the numbers on the table, but more over from the dental laboratory, that this is contaminated. You will see, not with the naked eye, but with a microscope, you will see spots of contamination. And only steaming of your implant components do not result in a decontamination that is sufficient to have a clean abutment surface. So one of my friends, Luigi Canulo, he published some papers around this topic, and he showed that only plasma cleaning resulted in sufficient cleaning of implant components. And why is this so important? Because if you have a contamination of the implant abutment interface, this will cause a wider microcap, causing more marginal bone resorption. And if you have a contamination of the implant surface, you will have local inflammation resulting in more peri-implant bone loss. So if we talk about stable tissues being minimally invasive in our prosthodontic technique, I think this is something that we should keep in mind. As a conclusion, I can say for our prosthodontic work, we have to optimize abutment configuration using biocompatible materials. It may be wise to install a definitive abutment as soon as possible, maybe immediate after the implant placement. And we have to follow a certain decontamination protocol for our implant components. I think to finalize this lecture, Philippe will give you or explain you how he applied all those principles for aesthetic implant treatment in a prospective study that he conducted at the University of Ghent.
Tommy, I think it's very important what you said, that the emergence profile and the concave abutments are very decisive for nice aesthetics and tissue guidance. But we would like to go in for a patient we did in that prospective study. It's a patient of about 45 years, where the central incisor had some root resorption, showed some root resorption. And there we had to extract that root, but we wanted to replace it immediately after extraction. So there was enough root resorption, and in those cases we try to use the new technologies that are also here presented with cone beam CT scan. And then we look at the buccal bone site, and if we have enough buccal bone before extraction, we can tell the patient to go in for maybe an immediate replacement of that tooth. But if we look at these designs, you can see that at the left side you have enough buccal bone, thick buccal bone, and soft tissues. But at the right side, the totally right side, it's a very thin buccal bone and also thin soft tissue. Well, I can tell you that most of the patients are at the right side, because Dr. Lee did a study in young adult Koreans, and he did some measurements, and the measurements were about approximately 0.70 millimeter, where most of the patients situated in that region. So we don't have so much patients who are like in the left side. So be very careful when you go for immediate implantation in the central incisor region. Here you see after the careful extraction and removal of the granulomatous tissues, that we placed the implant in a proper way to go enough palatally so that we have no problems with the recessions afterwards. Because we know from the literature, from Dr. Evans and Dr. Chen, that if we go too far buccally after placing the implants immediately after extraction, you get in problems. You get in problems with recessions to 1.8 millimeter in those cases when you go too much buccally. So you have to be cautious in those cases that you go enough to the palatal to place the implants at the good site. And therefore, I like also to use in already a few months in a new study for Enerich to use the Enerich implants, because this morning was said that when you drill the osteotomy site for immediate implants, the implants follows very well the drilling site, and you are not pushed to the buccal. And I think it's very important for the surgery to consider that and to have the good implants. So that's my experience in the 10 patients I did for this study, that it is a very stable situation with Enerich, and also a very nice implant treatment. Very important in this situation is all that if you go subgingival with acrylic, because there is no other possibility, you have to polish it very well and to have no bacteria adherence at that site. And then we go for final treatment. And I think it's very important also to give our technicians the way how they have to proceed in those things, because many times you have soft tissue models, and they put off the soft tissue and they do a modulation of the abutment and the crown, and you have problems. But here you have epoxy or gypsum models, and they are forced to follow these guidelines, and I think it's very important to show that to the technicians that he can perform nice crowns. And here's the final restoration of that patient, one of the patients of the study. Going to the prospective study design, there were two groups initially, a test group, namely extraction sites and immediate replacement with a temporary crown, and the heel sites with immediate loading. But we had also in group A and group B some patients who where the bone was not enough, and therefore we had to postpone them to group C to place them in a regenerative group where the sites were grafted before we placed the implants afterwards. The results of the implant survival were very good. I think 96% overall over 3 years, and now we have the 5-year data and they are the same. In the extraction sites we had a little bit of tendency to have more failures. And I think it's also a message to take home that healed ridges are very good predictability, sometimes 100% in some studies, but when you go to extraction sites, you have to be careful when you indicate these sites and to handle that if you have problems or mistakes. When you go to bone levels, we see a bone gain in the extraction sites about 1.80 millimeter after 3 years. It's normal that the implant at the coronal site and the bone at the coronal site grows in and you get a bone gain. And in the heel site, you have a bone loss about 0.4 millimeters. When you do an analysis of statistical analysis of these things, we see no significant differences between these things. The soft tissue responses of all these patients, in all patients we practically saw regrowth of the papilla, mesial and distal papilla, and that's a good thing. But for me it's very important to look at the midfacial situation, the midfacial soft tissue response. And there also we saw a creeping facial mucosa. This means we had some more tissue than we started in the beginning. So that is a good sign for immediate implant placement if you place it very correctly with the gingival zenith surgery, guided surgery, that in this manner you can have gain of tissues and stable tissues. Because when you look to the statistics, about 85% were stable or had a gingival advance in this group of patients. Another question is, does the biotype matter? We didn't talk a lot about biotype, and I think it's very important that you consider those patients before you treat them, and in your diagnosis that you look to the biotype, and if possible, if you have thin biotype, maybe you can go for implant placement, but then you had maybe add new techniques, new biomaterials to have the same results as you had by the patients with a thick biotype. And I think if you want to read about that, you can read in the publications from me and Cozain and Lyndon Cooper about these things. But maybe, Tommy, you can have a little bit comment on these techniques with the thin biotypes and how eventually you can provide better results in those patients.
Well, Philip, for me this is very easy. I consider all my patients to have a thin biotype. So whenever I have the opportunity, I insert a connective tissue graft as soon as possible in the stage of the treatment. So for me, this is in most cases starting from the extraction. I like to boost the gingival biotype, even in cases where I know it is thick, because it is very easy to remove soft tissues. It is very difficult to create them afterwards. So, I would like to finish with one last case, and this is a case that for me was an indication to perform all those treatments that we can do in a one-step approach. This is a young lady that has had a lost second premolar. So we decided to extract it very carefully, taking care of the nice architecture that we had. There was also a nice hard tissue architecture, so again we decided to preserve it. But in the same visit install an implant. This is an AnyRidge implant, long enough to achieve the very good primary stability. What I like a lot is that all those implants, they have a cover screw, and I use those cover screws just to prevent the biomaterial that I use in such cases to go inside the implant, because that is not good. It will make the implant components not connect properly if you have something in them. So I use the cover screw, and then again, a connective tissue graft that is inserted on the buccal aspect and a bit on the coronal aspect of the alveolar socket with some minimal or very small sutures. I wanted to proceed in this case with the provisional crown, and in this case we used a standard titanium abutment that has a transmucosal portion. You can choose the height of the abutment. I will use this abutment as the definitive abutment. So I will install it at the moment of my surgery, and I will try not to touch it again when I'm doing my definitive crown. And in order to do this, you need to because you always have to grind down a portion of the standard abutment. And I take a little impression just before inserting the abutment so that you can make an impression coping, individualized impression coping that you will use later for the final crown. So we worked with a provisional crown, cemented this crown on the abutment outside the mouth, remove the cement remnants, and then screw in the provisional crown, seal with some Teflon and then some composite. This is the case as the patient left the office. So, with this last slide, I would like to thank all of you for your very kind attention. I think it is wonderful to see so many people being here, even on a Saturday. It is almost evening. This is a very nice experience for us. Thank you very much.
Thank you.
Thank you. So it's a pleasure to participate in this meeting. It's a beautiful island and a beautiful hotel, and I'd like to congratulate Dr. Park and his magazine team for putting on such a great meeting. I said it before and I say it again, that one of the advantages of participating in a meeting like this is that I get to listen to other speakers and also new developments and catch up on new developments and so forth. And yesterday and today there were some great lectures and I really I learned a lot. My head is spinning with all the new instrumentations and new way of doing things. Now, my topic for today's presentation is aesthetic management in implant surgery. Minimally invasive approach. And it's kind of, if you listen to a lot of the speakers, they mention minimally invasive approach and minimally invasive way of treating patients. And that's kind of dear to my heart because I've been a proponent of minimally invasive approach to implant therapy, especially in aesthetics, for the last 15 years. And I'm glad to hear that more of that term, minimally invasive approach, is being used by many of the speakers. Okay. And I've been involved in implant surgery education for the last 27 years at UCLA. And other places in different parts of the world. And for next hour or so, I'd like to spend time with you sharing my philosophy in surgery involving aesthetics and different techniques that I have developed over the years. Of course, my approach and technique it reflects my bias and how I see, how I interpret dental implant literature and my clinical experience. And when I look at a case, what am I looking at? When I look at a case, what am I looking to do? And important as just much is that what I try not to do. And I like to share my thoughts and thought process as we go through cases. And we're going to be going through several cases. Everything worked fine about 15 minutes ago, and this usually... I wonder what happened. This is not working, maybe?
나가요? 잠시만요. 알겠습니다. Who's play?
So, aesthetic management and implant surgery, current concepts and technique, minimally invasive approach. One of the most difficult things is placing implants in anterior aesthetic zones such as this, where the alveolar bone has been destroyed by various type of oral disease, periodontal, endodontic, and so forth. And the morphology of these defects determine what kind of surgical treatment that we do for a patient. And morphology of these defects determines the osteogenic potential of these defects when we place the implants. The problem is, at the time of the examination, soft tissue covers over these defects and it's difficult to see. And the aesthetic nightmares such as these things occur when the integrity of the soft tissue over these defects, alveolar defects, is violated through improper surgical incisions, and the tissue is cut, and then, generally speaking, the soft tissue follows the alveolar bone morphology, and the collapse of the tissue occurs. And most of the aesthetic difficulties that we face are the defects between the dentition or implants where the interdental papilla is missing in quality and quantity. The proper, predictable aesthetic surgical treatment in implants starts with proper examination. And there are different components of examination for aesthetic evaluation in implant surgery, and mainly gingival status. Morphology of the gingiva in relation to the alveolar bone and how they relate to each other. And what's the osteogenic potential and the surgical treatment direction depending on the morphology of the osseous status is something we need to ascertain before we make a treatment plan. The teeth and shape of the position and the shape also determines the aesthetics. And parameter for predictable papilla, what I mean by that is that in a given situation, what's the height of the papilla that we could expect after the surgery. And all this information in relation to the aesthetic zone of the patient and the chief complaint, and we put it all together and we come up with a treatment plan that is most appropriate for the patients. For longevity and aesthetics, predictable aesthetics is our challenge and our responsibility. It is important to understand patient's chief complaint because not everybody wants the same thing. At the time of the examination and discussion with patient, it is important to determine aesthetically if a patient is looking for masterpiece or function. And so not every case that we treat in aesthetics, we need to create masterpiece. And there's nothing wrong with creating masterpiece, but it takes multiple surgeries and more cost and more surgical time, and not every patient wants that. So I believe it is important to determine what is the patient wants, and we'll put it all together with the examination data. Now, if I do the examination properly, looking at the clinical data and radiographically, I have a better chance of coming up with a correct diagnosis. And as long as there's a correct diagnosis, there can be many different ways of treatment. I'm going to be sharing my philosophy and the techniques and the approach that I take for aesthetic treatment in implant surgery, but that's not necessarily meaning that you have to do it this way. I've seen there are many different ways, and there are many successful cases with different ways, and I just want to show you, I want to share with you some of the alternative way of solving some of the aesthetic dilemma that we have dealing with the difficult implant cases in aesthetic zone. The treatment planning today is a little bit confusing because there are so many different ways of treating a same problem, starting with extraction and no extraction. Of course, there's a lot of debate on that. And then there is a one-stage approach to implant placement, and there are two-stage, and immediate placement versus delay implant placement, and one-stage bone regeneration simultaneously, and two-stage bone regeneration. Okay. And there is, of course, different type of bone material, autogenous, allograft, or synthetic graft, membrane use or no membrane use, and now we have a bioactive agents on the market. That when do we use these things and when do we not use these things? So just like this slide, it's very confusing sometimes. Okay? And there are many different aspects that is important to predictable aesthetics in implant surgery, but in my belief is that there are two aspects of different aspects of implant surgery that means more than the other as far as creating predictable aesthetics, and they are how we place the implants, whether we place implants in immediate one-stage implant approach or delay implant approach, and I want to spend some time discussing this. Now, immediate two-stage implant placement is somewhere in between as far as advantages and disadvantages concerned. And as we talk about immediate one-stage and delay implant placement, I think you'll be able to deduce what is the advantage and disadvantage from this direction. Now, talking about different implant sites and placement, as our colleague from professors from Belgium has discussed in their research, it's been discussed for many years, as long as that I can remember 15 years ago. So it's nothing new. Even in 1993, Wilson published the paper on immediate placing implants in immediate, recent, delayed, and mature, and talked about the advantages and disadvantages. It's nothing new, but I want to share with you my thoughts on where the advantage is and what the problem is and disadvantage is. So just to have our meeting of mind is that you know what I'm talking about when I say that delay implant placement is where extraction is done and we do some type of ridge preservation procedures using different type of bone grafts of your choice, of course. And then typically anywhere from 2 to 6 months we go back and place implant. This is what I mean by delay approach. So general consensus today is that in a soft tissue profile creation, immediate is good because it preserves the interproximal tissue, whereas delay is kind of bad because we lose interproximal vertical height. And but for the hard tissue management, immediate is compromised where the delay is good. And some of the data may seem to indicate that. But in reality, and this makes sense, conceptually it makes sense because, of course, if you create a bone and then you place the implant, the bone will be more stable. But then if you place an implant in the extraction socket and then bone has to somehow regenerate in the socket simultaneously as you get osseointegration, it seems like you have less control over the bone. And that's conceptually true. But in reality, is it the hard tissue management really compromising immediate and is really good for the good in the delay approach? And those are some of the things that I do want to discuss with you. So, in reality, achieving implant aesthetics, is delay implant placement always predictable? Is the one question I would ask. And delay implant placement, there's always some type of ridge preservation procedure done. And ridge preservation itself, is it always predictable, is the question that I would ask. In the posterior teeth, the ridge preservation is pretty straightforward. We extract the teeth, we place the some type of bone graft material. We could cover over that with a membrane to just keep the graft materials in place. And you can make it one layer, 2 layer, or 10 layers. And then we just keep it in place. And then we go ahead and let it heal. In about 3 weeks, 4 weeks, the epithelialization occurs, and placing implants is not a big issue. Is it possible I could get a better pointer somewhere? But in the anterior ridge preservation, it's a little different story. It's not just preserving the ridge that matters, but in the anterior aesthetics, preserving this unsported gingiva crustal to the osseous bone is what's important for predictable aesthetics. And preserving this tissue supracrestal, coronal to the crest of the alveolar bone, is unsported, especially in this kind of extraction is concerned. Of course, in the single implant, it's not that difficult, because the papilla height is usually determined by the alveolar bone of the adjacent teeth. Thanks. Okay, great. It's the alveolar bone of the adjacent teeth. Okay? And as long as the adjacent bone, bone is there, we can make mistakes by different using a. What under? 뭐? 이거 미스인 게 맞겠다. The pointer doesn't work, so the height of the interdental papilla is determined by the adjacent bone. Okay, so especially in the young patients, even if we go ahead and make a full flap and we don't even have a papilla tissue there, the papilla grows back. But in the multi-alveolar ridge preservation, it's a different story. It's preserving that tip of that tissue between the two extraction socket is very difficult to do. And also, in the cases where the scallop of the dentition is very pronounced, and the papilla height is more than 4 or 5 millimeters, as you see here, even a single tooth implant, after the extraction, it is difficult to preserve the interdental papillar height. It's very different from this type of situation where the teeth are more square, where the papilla height is not that great. It's easier to preserve the interdental papilla. And certainly you could see how this could magnify in situations where there's multiple teeth involved. So when we're dealing with patients with pronounced scalloping of the teeth, and we see this type of situation, especially multi-implant situation, then it is very important to have a good discussion with the patient, to have a meeting of the mind. What's the end result that the patient is expecting and what you can deliver. Now, there's a lot of, I listed the references of what I'm saying is reference-based. However, each of these references have their own biases and limitation, but I list them here because we cannot totally ignore them, but there are a lot of good information. For those of you who are interested, I list them, but we don't have a lot of time to go over them each individually, so I apologize for that. So, anterior preservation, does it really always consistently preserve the ridge? Let's look at this case. This is an implant failure with external resorption, and that too needed to be extracted. And this case is not my case, but Patient had extraction done, had rigid preservation done, grafting done, and tooth root was sectioned and attached to the adjacent tooth, and the patient comes back 6 months later. And this is patient had a rigid preservation done. But look at this. You can see that there is a tremendous horizontal resorption. Okay? And if you look at the last photograph of their occlusal photograph, shows that even with rigid preservation, there is a pronounced horizontal resorption. It did preserve, because of the it was done in flapless manner, it did preserve the interproximal height of papilla, but even in the cases where, and this is what we see a lot of times, even with rigid preservation, when we go back in 6 months and try to place the implant, there is enough bone to place the implant, but as far as the soft tissue is concerned, we end up having to do more soft tissue augmentation. So the alveolar preservation itself is not always predictable. How about and this is magnified in the multiple rigid preservation. If you look at that, so extraction, and our goal is to preserve the height of interproximal tissue that is unspotted now. And placing the bone graft in there alone is not enough to preserve the height of that tissue. If you look at that diagram up there, putting the bone, you can see the unspotted papilla. There's nothing to support that, and gradually you lose that and becomes flattened. Now you lost 2 and 3 millimeters of interdental tissue, and that is very damaging to the creating foundation for aesthetic restoration and implant therapy. Now there's a way of doing it. I've seen our colleague from Belgium doing that. Is putting a soft tissue in there at the rigid preservation time, just like I did here. Now, a little different from the approaches that you have taken is that because I don't want to take too big of a connective tissue, I took the connective tissue and slide underneath it to support the papilla, but it's not draped over the socket. So in a way, we're creating a three-dimensionally a tissue in that void to keep the interdental papilla. And I like to keep, if I have to do a rigid preservation, which I don't do that much anymore, and this is about, I've done this about almost 18, 19 years ago. So at that time, to keep the interdental papilla height, I used to, but to maximize that, I avoid cutting into the interdental papilla, keeping the integrity of the soft tissue over the graft tissue. And this is important, and we're going to see that more as we go through different cases. And then to keep the, so it's much better than cutting that. If I cut that papilla and interrupt the blood supply, then what we have is a situation where that collapse of that tissue is going to occur, and we will lose more height of the interdental papilla. So, but then to keep that connective tissue alive, because it doesn't have a lot of collateral circulation, what I do is that I go ahead and place a non-resorbable membrane underneath that to cage the connective tissue from our environment, and that kind of keeps the nutrient in and keeps the tissue alive. In about 3 weeks, you remove the membrane, and you can see that tissue has survived, providing a support for the interdental tissue. This is not a small surgery, by the way. It's I have to take quite a bit of connective tissue from there and place it. And this is a young patient also. Look at the ridge, and we preserve the ridge horizontally, and we preserve the ridge vertically. You can see that first photograph. See how the tissue is supracrestally generated to keep that interdental papilla in its position. But this is a young patient. But this ridge, and you could keep the scalloping effect of the gingiva foundation for the foundation, for the aesthetic restoration. But this is a young patient, and because of the ridge and because of their physiology, they retain more tissue, from my experience. But if you take this 72-year-old female patient with periodontal disease, and we extract these teeth, and now we got three papillas that we have to preserve. And in this kind of case, and this age of a patient with their physiology, even if I put bone graft in there, it's very difficult to keep those height of the interdental papilla, and gingival foundation, it's very difficult to achieve predictable aesthetics with that kind of situation. Now in magazine, we have all different kind of bone graft. You could put different bone graft on each one of those sockets and see how it works, but still it's very difficult to achieve that. I put photographs of the places that we had lectures at, just to break up the case so that I'm going to new topic or new case. Let's look at this case. And so the point is, the gingival preservation, the alveolar preservation, is not always predictable as it may seem. And depending on patients' physiology and their makeup and their bone anatomy, some are more successful than the others. How about delay implant placement? Bone regeneration always predictable. Let's look at this case. This patient had tremendous periodontal defect as well. You could see from the defect on the right, on the labial side of number 9, there's hardly any bone. A lot of infection. And so I extracted the teeth. And just keep in mind, when we're evaluating our results of the height of interdental papilla or gingival foundation, it's always good practice to find a reference points that are not changed during the surgery, through surgery, or restoration, and then compare our results from the previous, initial stage. And so keep in mind, when we draw a tangent line from the lateral to lateral and see where the interdental papilla is and also where the labiogingiva is, so that we could compare apple to apple, so to speak. So we extracted the teeth, we played, and that's the papilla. And we did a ridge augmentation procedure. Now, the papilla here is a little bit weak. In order to improve the papilla, I wanted to supracrestally build the ridge, and I did that. I built the ridge almost to the tip of the existing papilla, and we managed the flap. You see how it's brought down. But this kind of ridge augmentation procedure requires mobilization of the flap, thinning of the flap, the releasing of the periosteum, and it causes us a lot of swelling, and these surgeries are not really fun for the patient. And then it's healing in my hands when I hike these things down very much and do a vertical augmentation and horizontal augmentation. About 30% of the time I get exposure like that. If I get exposure like that, then patient management becomes a little bit more difficult. Make sure that there's no exudation taking place. But at the end of the day, I have gained a tremendous horizontal component to the ridge as well as a vertical height that I was very proud of. But after the second stage surgery and after the restoration placement, and I looked at this case about a year later, this is what I got. Okay? It's not a bad result. It's an acceptable result. Okay? But after going through these surgeries and putting patients through multiple surgeries, and what happened to the bone? This is on the photograph on the right is 6 months after, 6-7 months after the surgery. What happened to the papilla that I generated, the vertical height that I generated a year later after the restoration? It's gone. And this is what we see a lot of times with bone regeneration procedure. And this is what we see even with a solid block vertical augmentation procedures. Okay? And if we compare this result to the original photograph, okay, and look at the papilla that I had, and look at the papilla that I ended up with, what did I do for the patient was my question. Was it worth for that patient to go through that 3-4 surgeries to get this result? Is there a better way? Okay? I think there is a better way, and we'll get to that. But let's look at another case. Okay? This is a patient came in. She's in a lot of pain, and she says, "I want this tooth extracted." And I should have planned better. but I extracted it, and I said, okay, I'm going to preserve the ridge. I put the bone graft in there, and there was a lot of infection in the teeth, and I mobilized some of the teeth from the socket, and I covered over the graft, and I thought I did pretty good ridge preservation procedure for these. And it was pretty mobile, and she was in a lot of pain, so I had to take this tooth out. So about 6 months later, I did implant placement. At that time, this was about 7 years ago, I believe, 8 years ago. Salama came out with a technique called tissue-guided regeneration. It's by putting a healing abutment that is about 2 millimeters, and using that as a tent, we do a little vertical augmentation at the time of the implant placement. And I did that. And it seems to work, but after the patient goes back to the restoring dentist and do a provisional restoration, and patient come back like this. She's not happy. And I'm not happy. And after 1 year of 2 surgeries, and this is what patient had. Okay? So now I have to fix it. So when I do a vertical augmentation soft tissue procedures, again, I like to keep the integrity of the soft tissue over this bone weakness, and that seems to give me a best possibility of gaining vertical height. So, but then I need a lot of volume. So I put in the second photograph is 1 layer of connective tissue, and then I put a second layer of connective tissue on the labial side. You heard today, or yesterday or today, speakers talking about in order to support the vertical height that you gain, you have to simultaneously build a labial component of the ridge. And I needed to do that as well. So I put 1 connective tissue underneath the papilla between the implants, and then I put another tissue on the labial to build out. And after all the surgery, from here came to here. It's not a bad result. Patient was okay. I was okay with it, not 100% happy about it. And the bone is, the implant surrounding the bone is doing fine. So after 1.5 years, 2 surgeries, and after 1.5 years with 3 surgeries, this is what I got. But you could tell from this crown, from the contact is very long. When you have 2 implant restoration together and the contact is long, what it tells you is that you lost vertical height. Okay? So when I look at this case, okay, and then I looked at the original photograph and I used the reference line, and I look at the papilla before I extracted this, and I look at the papilla height after all said and done, I really haven't improved the vertical height on this patient at all. Okay? So these are some of the issues that I'm running with a delay approach to implant placement. Let's look at more extreme case. This is a mature ridge that has been resolved after extraction for a long period of time. So this patient, the canine is failing, the bridge abutment is failing, but the canine's got good roots, so it's not to be extracted, but we weren't sure if this patient canine could support another bridge, so we decided to place the implant, do individual crowns on the canine. And looking at a canine, bone level, vertically bone level seems to be okay, sufficient, but horizontally, obviously, we got resorptions there and concavities. And we know going in, and also from the radiographic radiolucency going in, that we're dealing with a very thin bone. And this is what we got after we reflected. This is a very difficult situation to place implant. Can we place implant? Dr. Park Chun-Hong talked about ridge splitting. Ridge splitting is a good technique. Case selection has to be there. There are certain cases that cannot accommodate ridge splitting. But in this case, I was able to split the ridge. I tend to split the ridge a little bit on the palatal side and place the implant and do a simultaneous bone augmentation. and using the resorbable membrane, because at that time, and this was also is a case that I've done a long time ago. And when I do this type of a bone augmentation, there has to be a lot of releasing of the labial flap. This creates a mucogingival problem, a lot of swelling. Again, this is not a fun surgery for the patient. But then I was able to gain the horizontal ridge. I was able to gain some vertical. And 6 months later, looking at the vertical ridge that I gained, it looked pretty good. I was happy with the result. There was a little red bleeding point. What happened was some of the graft material was showing through, so I popped that out. And there's no infection on this ridge other than that graft material surfaced, and I had to get rid of it. And the horizontally, I have good ridge. But looking at these in a direct, and if you take a photograph or the finished cases of restoration directly on, a lot of the horizontal component of the ridge deficiency get masked out. And sometimes it look really, but I wanted to do it. And so this is how it is after the therapy. And this is looking at the labia. We have preserved the horizontal component. We have preserved the vertical component. And the important thing is that with one surgery, which included extraction, 7 months, we had this final restorations on this patient. And during the healing phase, she never had to go with provisional partials at all. She always had fixed restoration. Okay? So this is where we started. And if we look at the original gingival margin and the final gingival margin and the interdental papilla, we have preserved it. So with any other approach, any delay approach or immediate two-stage, it's very difficult to achieve this kind of result on a patient at this age with this type of gingival anatomy. But with this procedure, and compensating for the inherent weaknesses of anterior teeth, the immediate implant placement, we can achieve predictably gingival foundation for aesthetic restoration. And with the gingival margin improved, now patient has much more youth smile when smiling. Okay? So is it possible to change the original gingival level with the crescent graft technique? Yes. Is it possible to preserve papilla between implants? And with this approach, yes. Okay? So this is a good armamentarium for you to have to solve some of the aesthetic dilemma that a lot of us face. And also placing two implant, platform switching implant design narrows that 3 millimeter rule to somewhere around 2.3 millimeter last time I heard. So, which is good. Only thing that I haven't heard before that I heard today from our colleague and the professor from Belgium talked about placing the implant 2 millimeter subcrestally. And I have to look into that more. It's an interesting concept. It's just that I haven't tried that, except in some cases where inadvertently that I have done that. Okay? But how it increases the strength of the abutment and so forth is not something that I've thought about, and I'm very glad that I was here to listen to that. Platform switch implant design. There are some concepts which creates controversy today. And one of them is the impact of implant design in bone and gingiva. And we talked about conical connection. We talked about platform switching. A lot of things that is improving our way of making this implant more friendly and minimally invasive for patients. And this is a good time. I just want to briefly touch that the things that I feel important as far as aesthetics and implant dentistry is of course, aesthetics and as well as implant dentistry in general is the surface integration versus plaque retention. Smooth surface implant is not good. Too rough surface implant retains plaque, and whenever we retain plaque, then you could have progressive bone loss. So you need to watch that. I like the that surface has to be just right, rough. Platform switching, I believe, is important for preservation of interdental bone, crestal bone, with rigid connection. Today you have heard from our colleagues and from professor from Belgium. And taper implant for immediate is much easier to place these things and get primary stability than other type. Short and wide diameter would treat some of the posterior cases, minimally invasive approach. And then I'm glad to see that the AnyRidge and AnyOneRidge has these characteristics that I think are important for implants. Okay. Now, some of the other controversy we have is implant placement in infected socket. There are some people says that if a tooth is infected, we should not place implant immediately. It's wrong. As long as we get complete degranulation, then there's no reason not to place implant immediately. Simultaneous bone grafting and the osseointegration of exposed surfaces. And these three topics, I'd like to cover it with the next case. And of course, I listed the references. And my approach, my philosophy to implant surgery has been minimally invasive, a patient-friendly manner. Because I guess deep down, I don't want to see patients suffer needlessly. But there are three important factors determining the approaches that I take for implant placement. And one of the important factors is the predictability. Whatever procedure I use, it has to be predictable. Okay? And the longevity has to be there. It has to last a long time. Okay? It cannot fail in short few years. And more importantly, it cannot create harm more than the procedures that we have. As long as these three principles is not violated, then I look for ways of doing things that will provide me more predictable aesthetics, minimum morbidity to patients. Okay? If approach I take decrease morbidity, but it also decreases the longevity and predictability, then it's not a good approach. Minimal number of surgeries, okay, because it is minimally invasive and timely and reasonable cost and has to be clinician friendly. And all these things are part of the definition of minimally invasive approach to implant surgery, patient management. Not just the surgery itself, not whether we make a flap or not, but if we could do the surgery in one session rather than 3 sessions, and we could do it in 3 to 6 months rather than 1 or 2 years, this all long-term long treatment to achieve aesthetics in implant dentistry is a very hard on patients, and we need to keep in mind of that. So, minimally invasive approach to implant dentistry, if we use immediate implant placement, one-stage approach, and if I use simultaneous hard tissue and soft tissue grafting, I could provide a patient-friendly treatment to the patient in a minimally invasive way. Okay, so let's look at this case. This case is 42-year female patient, had this bridge done. She had huge abscess. There's just a lot of exudation coming out. I had to put the patient on antibiotics to calm the tissue down, and this is after about 5 days to 6 days of antibiotic treatment with chlorhexidine oral hygiene instruction. Tissue was much more angrier than this. X-ray shows that there's endodontic, periodontal communication problems, and I could take this case with that kind of bone loss in the anterior. I could take this in delay approach, and this is not the same case. But I have cases like this before. If I take this and I extract these teeth and let it heal, this is kind of a ridge that I'm going to end up with. And to bring this back up, you've seen some of those surgeries, distraction type of surgeries, putting huge block of bone graft and so forth, is what's necessary. Multiple surgeries necessary to get decent aesthetics. So I don't want to go there. Can we do this case immediately with simultaneous bone grafting? look at this situation after the extraction. I go ahead and degranulate the infected tissue completely. And I look at the lingual bone status. I look at the buccal bone status. And I measure the distance between the lingual and the buccal. Okay? And I used a stent, surgical stent, to see where the implant should be. And then I evaluate the implant position in relation to the osseous topography. And that gives me an indication what the regenerative potential of this defect around the implant that I placed. Okay, so I need to read the bone whether if implant placed here in this socket, that damaged socket, is going to grow bone predictably or not. And that's the key. So, and also there is a after the bone grafting implant placement, what is the most effective soft tissue management that I could do in this case. So, visualizing where the implant should be, looking at, there are three things that I evaluate, I ascertain, to see the osteogenic potential of this case. And first thing is, I look at the position of the implant buccolingually in the bone contour of the ridge. This is very important. Okay? What I mean by that is that if I place the implant in this side, and I look at the labial position of the implant, and I know where the lingual position of the labial position of the ridge, and I know where the lingual position is. Okay? And as long as these implants are intraosseous in the frame of envelope of the bone, then you have a very good chance of most of this implant surface is going to be submerged in the bone after the socket healing. Okay? And okay, so this distance from the labial envelope of the bone ridge to the implant surface is very critical in determining what kind of bone regeneration I'm going to get around this implant. Okay? And that's been published by several authors. And one of the authors is Tinti in 2003 discussed about implant position and the regenerative capacity. So in the class 1 and class 2 socket has a lack of labial bone, but it's within the socket. And in this type of situation, the studies have shown that you have 80 to 95% chance of exposed implant being covered with the bone. Okay? And then in the dehiscence defect, and in that if you have class 1 and class 2, class 1 dehiscence defect has a good chance of bone reforming around the implants. Okay? So in this particular case, what we're looking at is a few positions that is class 2 extraction position, and then some of the other ones are class 1 dehiscence, which means it's a favorable bone regeneration situation. So you combine this information with the second category, second criteria, and that is the implant, head of the implant position, vertical position of the implant in relation to the crest of the ridge, adjacent bone. What I mean by that is that where is the adjacent bone height? As long as that adjacent bone implant is below, you have good chance after the socket formation that implant is going to be in the bone. Okay? But this has to be thought of in three-dimensional way. Now look at this case. Okay? And also, the next criteria is the distance of the adjacent bone to the implant surface. I'm talking about jumping distance. Okay? So, jumping distance, as long as, and now the literature shows that jumping distance of 4 to 5 million has capacity to close up. But in these kind of clinical cases, that I like to stay within about 3 millimeters. As long as the jumping distance is about 3 millimeters or less, I know that I could get bone regeneration around that. Let's compare this case to another case. Okay? This is another case. This case is very different from this case as far as the regenerative potential of this defect because jumping distance is more than 3 millimeters. difficult to regenerate bone on this one. Now, iGen type of membrane I think should be very helpful here because it maintains the space better. But in this case, I decided to put a implant and submerge it and use it as a tent and just bury it with new bone regeneration. Okay, so I need something like that to support the membrane. Or you could also use a non-resorbable membrane with some type of a titanium reinforced or iGen. But then sometimes, at least iGen maybe not, but previous ones I had to make a huge flap to take out the membranes, and I didn't want to do that. So I used, oh, what happened? I'm sorry, I think I pressed the wrong button. Could somebody help me get the... Oh, here it is. So I used bone graft around it and put the pin as a tent, and regenerated the bone, and I just buried that the tent pole there. But in this case, jumping distance is less than 3 millimeters. So I put all this information together in a three-dimensional image, and I could see that, and that's the final rest. But you still get a little bit of shrinkage, but it's still good. So this determining the regenerative potential of the osseous defect that we have is something that we're used to in periodontics because we used to regenerate bone around the natural teeth all the time. Okay? So 1 wall, 3 wall is better than 2, and a 2 wall is better than 1 wall. Okay? So, and it's the same principle around the implant as well. Implant bone regeneration is not that different. In this case, where the labial bone is missing and the palatal bone is missing, we're dealing with 1 wall defect. And very difficult to regenerate bone around the implant place when we have this kind of situation over there. And those kind of situations should not be attempted with one-stage immediate simultaneous bone regeneration. The success for that is very low. Okay? So I just want to make distinction there. So in this case, this is a labial bone margin, and the bone is going to heal like that because the bone is adjacent bone. The bone height is there. The head of the gingiva is below the height of the socket, and you have space between the labial portion of the bone and so forth. So most of this defect is most of this exposed implant is gonna be covered with bone, healing socket, and I just put bone graft in there to help out the process. Little autogenous bone to increase the osteogenic potential. It's a one-stage surgery because flap management is more predictable that way, especially lower anteriors. I use resorbable membrane. Of course, I use allograft to bulk out, okay, and overbuild and close it. Now, as far as the regeneration of the bone around the implant is much more predictable than natural dentition, because in natural dentition we need to create cementum, periodontium, and we're dealing with the infected surface, where implant, all I have to do is regenerate bone and gingival on a sterile implant surface that is non-mobile. So it's much more favorable situation. Also, does the regenerated bone integrate with the implant surface? There are several studies that shows that they do. This is a research done by a person group in 2001. Shows that after the bone regeneration, after the implant, that there's a reintegration occurring with the regenerated bone on a rough surface implant, but not on a smooth surface implant. Okay? So implant surface is important. And also that is why you cannot take a research or a conclusion from one study and extrapolate into another clinical situation with different implants. There's another study that shows if you create a space, then bone formation does occur, and bone formation, the formed bone, regenerated bone, integrated with the previous infected surface even. So there is a literature support for that. This is how the flap is closed. Labial portion is released just a little bit. Not as much if I'm trying to get a complete closure, just enough to create tension-free closure. The abutments are exposed, and the provisional restoration on this case is placed 2 weeks later. Okay, and this is two years later. Okay. So we maintained most of the ridge interproximal height, and it's much better than if I would have taken this in a delay approach. And we've gone to this status from here in 6 month time with one surgery which included extraction. So this is a good alternative to some of the dilemma sometimes that these type of creates as far as the aesthetic dilemma is concerned. Is that stable? We look at predictability and longevity. This is 4 years later, and this is going on about 7 years, and I've seen the patient, and there's no change in the gingival level or the bone level. So it is stable. I think one of the stability comes from the fact that I did not disrupt the implant gingival junction, going back and forth with different surgeries and so forth. So 4 years later, the mucogingival junction is much more normal than if I would have taken this in delay approach. And okay. And if I would have taken in the delay approach, this is kind of situation occurrence. So we've taken radiographically from here to there with the bone level that you see. So it's very effective technique if we read the morphology of the bone and determine the regenerative potentials of these morphology in relation to the implant placement, and case selection is done properly, and it is a very predictable, and I think it creates less aesthetic nightmares than the other approaches that we have. Here's another case where this is a 67-year-old female patient. This is where the problem is. Of course, she had problem in the mandible, and I did maxilla and the mandible surgery simultaneously, and an exudation coming out. And we removed the prosthesis and the bone defect around the implant. That implant was removed, but I placed the another implant, of course with surgical planning and so forth. I placed another implant mesial to that failing implant and distal to that failing implant to repair that situation. This patient had these implants treatment done no longer than about 3-4 years before, and having a lot of problems. She doesn't want to go through a lot of surgery. So with the surgical modalities that I have, I've treated this case. And the reason I want to show you is that after removal of the implant, to the mesial there was a thin ridge. Okay? And I have choice of regenerating this bone and going back in 6 months and having patient be in surgery for a year or year and a half. I decide to do ridge split. It's like the technique that Dr. Pak has talked about. Okay? And the reason I did ridge split is that when I do the ridge split, it essentially expands the envelope of the alveolar bone housing, and in a sense, I'm putting the implant in an intraosseous manner in relation to the bone. Okay? So I'm creating the ridge width and placing the bone intraosseously. And of course, the ridge augment technique. This autogenous bone was taken from the mandibular surgery. One of the speakers mentioned that do simultaneous surgery so that you could gain these. And this is where the implant is placed. That whole distal surface of that implant is exposed. Okay? But then that implant is in an intraosseous position in relation to the newly created labial and the palatal plate of the bone. And we put the bone graft in the membrane and close it up. And then the last implant was treated. There's a little bit of infection. It was treated periodontally to get rid of the infection, used as a denture abutment for the healing phase. Okay. And this is where the bone graft came from. When the mandibular implant also failed, extracted, we placed the wide implant, rescue implant in the posterior, so I don't have to regenerate and wait another 6 months. And then to place the implant on the labial side, I needed to smooth out the ridge, and I took that bone from that ridge and placed in the maxilla. So we've gone from here in 9 months, from there to there. That bone has grown almost to the top thread of the implant. From the distal surface that was totally affected. So essentially that whole distal surface was totally regenerated with the surgery. So similarly, reading the bone and doing simultaneous bone graft. This is what we started. And what essentially we did is we put 2 implants, extracted that middle implant, placed 2 implants in that position, and the mandibular implant, the posterior implant. And then, supracrustally in a way, we regenerated that bone. So this bone has been regenerated, and that's that level right there. Okay, and finally, what do you do with the soft tissue defects that you have, something like this? Okay, so this case is the same patient in the anterior, and the implant has been placed very too apically. And what the problem with this type of restoration, and this type of implant and this type of restoration is that because of the long crown and because it's an external hex, when mastication is done, there's a micro gap created. Okay? It's like percolation effect. With that percolation effect, there's a bacterial accumulation, and then usually there's an abscess formation occur on the labial side, and then you have a recession. And this happens a lot. Happens a lot less with kind of connection that the any ridge has, because it kind of seals in the implant. So micro gap is not an issue. There's a lot more rigidity there. But in this kind of case, we see that sometimes. Now, I could take this implant out, then it's a big surgery. But I felt that if we could change the restoration, watch the occlusion, okay, and then repair and give a little better biotype on the labial side, I have seen these kind of cases be stable for many, many years. So that's the approach that I've taken. Rough abutment, I need to smooth that out. So I took the abutment out, smoothed it out, and mucogingival surgery. Mucogingival surgery, the labial recession like this does not concern me. This is a very predictable surgery. Okay? And we know that from doing root coverages on the natural dentition. As long as the exposed root or implant surface is intraosseous in relation to the bone housing, as long as interproximal bone is there, regenerating the soft tissue on the labial surface of this exposed implant is not very difficult. Okay? So, first there's a frenum pool. I take out the frenum. And so in the soft tissue augmentations involving coronally positioned graft, I like to utilize a surgical technique that maintains the integrity of the interdental papilla. Yeah, that gives a better circulation and better blood supply to the connective tissue that I place there, and better the connective tissue survive, I have a better shrinkage and a better coverage of this exposed implant. But sufficient release needs to be done into the interproximal area. so that there's no tension created, and there has to be room for connective tissue to be placed. And then again, this one, I need 2 layers. Okay? 1 layer, and then a second layer. And we place it in there. Okay? And also build out the labials of adjacent teeth a little bit to horizontally support the vertical augmentation at the gingival level. Okay? And of course, abutment is smoothed out and cleaned and tightened so that they'll be in good shape. And then this is how, but you can see that interproximal bone, the bone adjacent to the defect is almost healthy. So that is a plus for predictability of this procedure. So we went from there to there with 1 surgery. Okay? Now, this is not a masterpiece aesthetics. This is what I call 70-80% aesthetics. And patients fine with that. This patient is 67-year-old, doesn't want to go through a lot of procedures. And this procedure was done while waiting for the posterior bone regeneration. So the total treatment time has not been affected. So these are things that... So this brings to the final controversy that we have. How much bone on the labial is necessary to maintain the gingival level? Okay? Now we talked, I think we heard some speakers say that 2 millimeter is enough or 1.5 millimeter, I'm not sure. Of course, thicker the better. But what's the thickness that is required to keep the gingival level? Okay? So thickness of labial bone. This case, I had to do biopsy on this patient for a different reason. When I look at this labia on the second stage, I had less than 0.5 millimeter thickness of bone on the labial of this implant. Okay. And I did the soft tissue, improved the biotype, and then this is canine, and gingival stability was there. And 4 years later, that gingiva is still stable. And I did not re-augment the bone on that case. So what does that mean? I know there's a lot of study that taking place right now saying that thicker the bone. And so they do a procedure and they measure the success of the case by how much thickness of bone that we regenerated. But as far as the stability of gingiva is concerned, there may be something else at play. Maybe, because a lot of these are single tooth implants, maybe not the thickness of the labial bone that is important for stability of the gingiva, but the position of that implant in relation to the adjacent bone that is as important. Okay? So that's the food for thought, and I really don't have a proof of that, but I am looking into it because I have so many cases that there is a thinner bone and yet gingiva is not receding. Biotype is important. As long as there's no dehiscence, there may be that's all it takes in the single implant to keep the gingival margin stable. In a multiple implant, that type of intraosseous relationship to the adjacent implant is more difficult to achieve, and maybe we're looking at type 2 kind of situation, and that's where the recession occurs. And that's where thickness of the bone is important. So there's a difference between the single implant and the multiple implants. Okay? So I'm not here to suggest that my way is the best way, but I hope that for those of you who are not using the type of approach to implant placement for aesthetics that I've shown you here, would give you an alternative solution to some of the dilemma that you face in implant surgeries involving aesthetics. So if we take the immediate implant placement, one-stage approach, simultaneous hard and soft tissue, and we take these procedures, we have what it takes to treat patient in a minimally invasive, patient-friendly manner. So, thank you for allowing me to share my thoughts, and for those of you who are not from here and came from far away, please have a safe journey home. Thank you.
Thank you. Thank you very much.